Chapter 16, Part 2. Now that we have looked at the pathophysiology and reviewed the anatomy, we're going to look at how we treat our cardiovascular emergencies. And it starts the exact same. You'll be sick of seeing this and hearing this every emergency trauma or medical that we run, and that is scene safety and PPE. You must ensure, even if you think that this is going to be a normal scene, that it is safe from pets, from people, from any other type of danger that is there. You've got to look at the nature of illness, recognizing that your dispatch information is going to give you some idea, but you also have to remember that the normal public really doesn't necessarily understand the difference between cardiac event or just chest pain that is non-cardiac, and so when they answer the questions from the dispatcher, it's possible that it's going to give the impression that it is something else. So while we use the dispatch to guide us and give us some sort of insight, you need to ensure that you're not becoming very tunnel vision just because of what was said during the dispatch. Once you've assured scene safety, you need to form your general impression. Again, are they responsive, unresponsive? What's their color? What's your gut say? You need to check the airway and the breathing. Is it open? If not, open it and put an airway adjunct in. Are they breathing adequate to sustain life? If they're not, let's give them 2 breaths with a bag valve mask. Consider the application of oxygen at this point to assist your patient, 15 liters via non-rebreather. If the patient is suffering from congestive heart failure, from pulmonary edema, while you're not necessarily going to see this immediately, because this is the primary assessment, you do need to begin the consideration of whether or not whether or not CPAP is going to be successful in treating your patient. Once you've checked airway and breathing, then you move on to circulation. Circulation being, do they have a pulse? If they don't have a pulse, you're going to start CPR. If they do, you're going to look skin color, temperature, and condition. You're also going to look at the regularity of the pulse. Is it abnormal? Is there some sort of issue with the rhythm of the pulse? And of course, do they have any major bleeds? And after you've done that, you've done your head to toe bleed check and checked your skin color, temperature, condition, and pulse, that is when you're going to make your transport decision. If this is a patient with unstable angina, so they have taken nitro, it doesn't work, they don't have a history, or they're just in severe pain, then this is a load and go patient. And you need to consider the fact that while they may be a load and go patient, there is the chance that running to the hospital, lights and sirens, code 3, loud, crazy, driving fast, will actually be harmful to the patient. So it might just need to be what we consider kind of a fast code 2. So no lights, no sirens, but you are getting there in a quick manner. Once you've done the primary, we're going into that focused exam. So we're looking at the chest to determine if there's any traumatic injury. We are asking questions about sample and OPQRST so that we can determine if there's a history at all and if they take any medications, and also get some of those more important questions like, is there a radiation? Do you feel the pain somewhere else? Those types of things. Here is the OPQRST for cardiac emergencies, and just kind of a guide on some of the questions that you can ask specific to chest pain. So when you look at quality, you don't want to give them the words, but you want to guide them to a better description. So don't ask them, does it feel like an elephant sitting on your chest? Because it's possible they'll just say yes, expecting that's what you want to hear. But table 16.2 will show you a better idea of some of the questions to ask to get the information you're looking for. So then we get into our physical examination, where we're not only going to look to see if there's any trauma, but we're also maybe going to check to see if the respiratory system could be involved. So listening to breath sounds. taking a full set of vitals as well. With these patients, we're going to reassess every 5 minutes, and we need to be concerned with the fact that any cardiac compromise, cardiac emergency patient, we might be looking at the potential for an increased risk of sudden cardiac arrest. So always be prepared with the AED, not necessarily putting it right beside them because that's not what we're looking for, but maybe just prepared in terms of having it readily available and knowing that it is functioning. And of course, we continue to reassess our interventions and provide the appropriate transport to the appropriate facility. So as you've gone through your assessment, you are making the decision whether or not your patient meets the criteria for additional interventions, such as drugs. One of the first drugs is oxygen, which if they are having chest pains, oxygen should not be withheld. An additional treatment that you can consider is aspirin, and some of that's going to be based on your protocol, but some of that is also going to be based on whether or not they have issues associated with aspirin, some of the contraindications. And you're also going to consider any prescribed nitro. So what does aspirin do? Why do we give aspirin? A lot of people originally think it's for the pain. And if you're one of them, great, but after this lecture, you'll understand it's not. So we give aspirin because we are looking for the patient to have a level of preventative medicine, not for the pain necessarily, but because aspirin will actually coat the clot. So if you think of the clot as kind of a crystal, so it's not smooth. It's got jagged edges that actually make it easier for it to stop and get caught on plaque and other areas in the blood vessels. And the aspirin's design is to coat it so it prevents it from sticking to anything else or becoming bigger. The recommended dose is 324 milligrams. So if most of what your low dose aspirin comes in is the 81 milligram chewable tablets and what we carry on the trucks too, and you want to give your patient 4 unless they've already taken aspirin or they take daily aspirin. Nitroglycerin, we recognize that it can be in many ways, including a sublingual pill, sublingual spray, or even the skin patch. But most of the ways that we give it is going to be that sublingual pill. And what does nitroglycerin do? Well, nitroglycerin's action is to relax the blood vessels, allowing for an increased flow of oxygen supply. It will then decrease the workload of the heart. So it is a vasodilator. So it dilates the blood vessels. Some of the side effects associated with nitroglycerin are severe headache and a change in the pulse rate, because we're decreasing the size of, or we're increasing, sorry, the size of the blood vessels, and we are decreasing the workload on the heart. We anticipate a decrease in the pulse rate. Why don't we give nitro? Well, because of that dilation of the blood vessels, we are seeing a decrease in the blood pressure. If your patient is already in cardiogenic shock and already has a blood pressure less than 100, then you don't want to give that. Your goal is not to put them into hypovolemic shock. If your patient has a head injury, we don't do that because a head injury, obviously the last thing you want is for blood vessels to be bigger and for there to be more blood moving through any of the damage. We've talked about the erectile dysfunction drugs. Erectile dysfunction drugs are slow to leave the system, so you've got to ask about them within the last 24 hours. And erectile dysfunction drugs actually act the same way that nitro does, and that is that they vasodilate, and you do not want to basically give a double dose of that. Our maximum dose is 3 pills. Keeping in mind that you give a pill, you reassess after 5 minutes, you give a pill if needed, you reassess, you give the 3rd pill, and you reassess. So we give 1 pill at a time, reassessing afterwards. You've got to make sure that it's the 6 rights. So this slide only mentions the expiration and the patient, but don't forget that it's the right route, So if it's a sublingual, that's the way it's being given. If it's the right dose, you're giving one pill at a time. It's the right medication, you're giving it to the right person, and that it's the right time. You've done your initial vital signs, you've completed your first assessment, all of that. Wear gloves. Nitro is easily absorbed through the skin, and if you put it into your hand without gloves on, you will actually begin to absorb some of the nitro. And obviously, if you don't have issues with your cardiac function, it's not going to be a good thing. We look at the need for cardiac monitoring, and for the most part, this is an ALS skill. You see a lot of areas doing 12 leads or allowing a BLS provider now to put on the 12 leads and just send it to the hospital, so not actually interpret it. You need to consider that as a BLS provider, your ALS provider may be asking you for help in supporting the administration of the cardiac monitor, the placement of the cardiac monitor. You've got to make sure that there's little interference when you're running it. So you don't want the ambulance to be moving. You don't want your patient to be moving. You shouldn't be doing an intervention to your patient while you're trying to get the 12 lead. If you've got a hairy patient, you're probably going to have very little success in getting the electrodes placed. You may need to rub an area with alcohol if they're very sweaty or they have very oily skin. We always want to put the electrodes on the cables before placement, mostly because it's a snap and you don't want to have to press on your patient. And, always make sure you've got the electrodes in the right place so that you're getting the right picture of the heart. Go ahead and learn this. This shows the rib cage. So it is 12 leads, but that's kind of deceiving. 12 leads means 12 pictures from 12 different angles of the heart, but there's actually only 10 leads. And the first 4 are the white, black, red, and green that you see on the left-hand side. White to right, red to ribs, smoke over fire, and then green is the only one left. And then the other 6 and their placement, placing V1 and V2 first, and they're going to go at the 4th intercostal space on the right and the left side of the sternum. And then leads 3, 4, 5, and 6 are going to kind of circle the bottom area of the pectoral right under the nipple. And this should be in the anatomical position, not in the position that if you have a well-endowed patient, man or woman, where everything sits as they lie on the ground. Once the electrodes are in place, you will turn on the monitor. You will print a strip, and then you need to sometimes consider whether or not there was what's called artifact or interference. Again, this is going to be based on your agency. I can't stress enough to understand what the expectation is as an EMT basic with your agency on running or placing a 12 lead on your patient. But the goal is that you should get a 12 lead before and after intervention. Now, that does not mean withhold the intervention to get the 12 lead, but it is a way to understand how the intervention affected the patient. We see a lot of patients who have had open heart surgeries, and we are seeing an increase in the number of patients who have what are called cardiac assist devices. So you should probably just have a basic understanding of the different types of heart surgeries. And you can't necessarily know all of them, but these are the big ones that we tend to see. Mostly because it gives you an idea when your patient says they have a history of a bypass, you know that it's coronary, or you understand what that means or why it happened. So a coronary artery bypass is when a vessel from another area of the body that is clean and has less blockage is sewn from the aorta to the coronary artery. So basically it's a bypass of an obstruction that exists in the coronary artery. You can have a patient who's had a percutaneous transluminal coronary angioplasty. That is not how they'll say it. They'll probably just tell you they've had angioplasty. This is the procedure that's done when a patient has a narrowing in their coronary arteries. So they have not necessarily a blockage, but it is narrow. And they feed a balloon, uninflated balloon, into the coronary artery and then inflate it to push the blockage, to separate the blockage and increase the diameter of flow. You might have had patients who have open heart surgery that have the long, what we call the zipper scar. So they've basically been cut from top to bottom of their chest and then sewn back together. But that's not everyone now. As technology improves, the scarring that will give you that visual clue that your patient has a heart history isn't necessarily existing. We do have to make sure that if they have any of these issues, if they've had any of this history, it doesn't change how we treat the patient. Whether or not they've got these scars or they've got a surgical history, the patient should be treated the same unless there is some sort of contraindication for them not to be. So you're still going to do your primary assessment, secondary assessment, vital signs, and give medication. You might encounter a patient who has had a cardiac pacemaker implanted. So a pacemaker ensures that the patient's heart rate is maintained at a specific level. It's often given to patients who have a heart that isn't beating at the right rate or with the right force. So for whatever reason, I may be sick and my normal heart rate, even without medication, is sitting in the 40s. So a pacemaker will get implanted to ensure that my heart rhythm stays in the appropriate range, 80 to 100. And it does that by sending extra electrical rhythms to get those extra heartbeats in. It's not going to override the heart, but it is going to kick it into higher gear. This is kind of what a pacemaker looks like. It is put into the muscle of the skin and then the wires fed into the heart. It is a very reliable technology and has continued to increase in its reliability. And they're much smaller than they ever used to be too. And when it's implanted, you might feel a small bulge above the area of the heart in the left chest area. Unfortunately, when the pacemaker malfunctions or dies, obviously it's no longer going to make sure that heart rate is up at the right level. And so you'll have a patient who is dizzy, faint, anxious, has a significantly low heart rate. And we need to make sure that we are transporting these patients promptly, because the only thing that's going to help them is a surgical intervention. You may have patients who have an automatic implanted cardiac defibrillator. And all this is the exact same thing that we use. It's an AED, except it's internal. It sits within their hearts, is normally normally put in because a patient has a history of ventricular fibrillation and an inappropriate rhythm. You have the ability, it has the ability to constantly monitor the heart rhythm and shock as needed. As with a pacemaker, as with any patient, we're going to treat them the exact same with the appropriate assessment, vital signs, and treatment. It's possible that the defibrillator's batteries have died or it has malfunctioned. If it's malfunctioning to the point where it is firing even when it doesn't need to, you need to know that this is not something that will affect you. The electricity is low enough that you don't need to not touch the patient if they're being shocked by their implanted defibrillator. On the reverse, or on the flip side of this, are patients who have what we call an external vest defibrillator. So it is just that. It's a vest that they wear on the outside of their body that has pads that go into an appropriate place when the vest is worn, and uses high energy shocks to deliver the defibrillation. The difference here is that high energy. So that when that vest is telling you it's going to shock the patient, you need to come off. Don't touch the patient. If the patient is in cardiac arrest, then you need to still do CPR and leave the vest on unless it's going to interfere with your ability to do high quality compressions. And lastly, we'll talk about the left ventricular assist device, or an LVAD. An LVAD is designed to be implanted into the patient's left ventricle to assist in the left ventricle pumping. You will see this a lot in patients who have congestive heart failure, or who have a heart that does not have appropriate contractility. So it might have an ejection fraction of 20% when we need to have it at 80. It is a continuous flow. It's basically a fan that ensures that the oxygenated blood is coming out of the left ventricle and moving into the aorta. There is a battery pack that is worn in a backpack or a vest. And those wires are going to run outside the patient, and it's going to maintain the patient's heart rate. If the batteries die, there's a handle, and the patient knows and has been trained on how to function the LVAD when batteries have died. You may have a patient who has an LVAD, and they will likely not have a pulse because the left ventricle is not contracting. That is the whole point. A lot of times LVADs are put into patients to allow the left ventricle to heal, to allow it to recover from whatever trauma it had, in the hopes that either they can bypass a heart transplant and not have to get it, or that it keeps a patient alive long enough until they find somebody who is a match and they can get a new heart. What happens when we have a patient with no heart rate? I really hope you're all going, well, duh, Karen, it's a cardiac arrest, because that's what it is. Before CPR and defibrillation were developed in the 1960s, if you went into cardiac arrest, you died. It was that simple. We didn't have processes or an understanding of how to restart the heart. We use in the field, and what we see in public places, is an automated external defibrillator. The automated external defibrillator will identify ventricular fibrillation as a shockable rhythm. Remember, that's when the ventricles quiver, and it will administer a shock when it recognizes this after analyzing your patient's heart rhythm. There is some operator interaction that has to occur. This isn't an automatic defibrillator, it's automated. So someone's got to put the defibrillator on the patient. Somebody's got to turn it on. Somebody's got to hit start. It will walk you through the steps. So most of ours are semi-automated. So, okay, push to shock, shock advised, push to analyze, push to shock. You can't just put it on and put your feet up and say, well, here we go, let's go to the hospital. Why do we enjoy the AED? What do we see as the benefits? Well, they're right there. I don't need an ALS provider to apply and utilize an AED. If they weren't easy to use, we wouldn't be placing them in every sort of large public gathering location. We get more efficient shocks with the appropriate pad. And by putting pads with adhesive on the patient, I can step back. I don't need to use the paddles where there's a greater chance that I'm actually going to be touching the patient directly and increase my risk of shocking myself. And while not all cardiac arrests are shockable, all cardiac arrests should be analyzed. I'm not going to know until I put the AED on my patient whether or not they are shockable. So I need to put an AED on my patient who is apneic and pulseless. So I put it on my patients who are apneic, so not breathing, and pulseless, don't have a pulse. I do not put it on a patient who is neither apneic nor pulseless. I'm not going to shock asystole. That is not one that I shock. And pulseless electrical activity, there's no rhyme or reason to how the heart is getting its electrical stimulus. That is not going to be shocked either. Early defibrillation is key. It is one of the chains of links on the chain of survival. So if I don't put the AED on, then I'm not securing the opportunity for early defibrillation. This, again, as a reminder, is the chain of survival associated with cardiac arrest. CPR is going to give me a period of increase for which defibrillation will be effective. So the quicker I can start CPR, and the better I am at it, the longer opportunity I have for defibrillation to be successful in bringing my patient back. And we're training everybody. Okay, so don't think about the fact that this should only be for EMS providers or it should only be for ALS. We are putting AEDs everywhere and kids are being trained, kids, adults, the like, it doesn't matter. We would prefer advanced life support intervention for some of those drugs, for the more advanced airway, for the ability to do more advanced interventions as necessary. But we don't necessarily need to. And then we need to consider some of the other issues that might have happened. We need to get the blood pressure up. We need to check glucose levels. All of these are things that might affect the electrical stimulations on the heart. Remember that you should not stop CPR for any longer than necessary, which is no more than about a minute, while you analyze and shock the patient. You can't do CPR while you're analyzing the patient, and you shouldn't touch the patient because any artifact, it's possible the AED could even catch your heartbeat and then say that it is a non-shockable rhythm when it should have been. We must maintain our AEDs just like every other piece of equipment. Understand how it fails. Understand that most of the time when an AED fails, it's because we didn't correct it. We didn't fix it the way that it needed to be. We didn't check the batteries. We don't have the right pads. All things that we can do and we can ensure are being met. Medical direction needs to recognize what the AED policy is and develop that protocol. For the most part, it's that you transport after 3 shocks or 3 no shocks. And then, as we said, we need to, in the BLS chapter, we need to be doing continuing education with hands-on training to ensure the most effective CPR is delivered. How do we prepare? Well, when we have a patient who is in recognized cardiac arrest, you need to make sure that they're in a safe environment. So that means that there's no electricity, they're not sitting in a pool of water, and they're not touching any metal. There's some horrible stories associated with people who have shocked or tried to shock or even thought about shocking cardiac arrest victims as they laid on a metal set of bleachers at a large sporting event. And that would have turned out very poorly for everyone involved. If they have a nitro patch or something else, you need to go ahead and take it off and wipe it dry. We talked about shaving a hairy chest to increase the conductivity of the pads and so that you don't have to smell singed chest hair. And you need to consider whether or not spinal immobilization is necessary. Is this a traumatic cardiac arrest? When they went into cardiac arrest, did they fall? Is spinal immobilization important? This is a good flow chart for you to understand what's happening. So if you use this flow chart, it tells you what to do as you arrive on scene, recognizing the patient's unresponsive, recognizing whether or not they have circulation. So if your patient has circulation but no respirations, all you're going to do is rescue breathing. If they have neither circulation or respiration, then you're going to get into CPR and the AED. You need to keep in mind that, remember, after every no shock, you need to check for a pulse. Maybe your patient's pulse came back and you didn't quite realize it. And the last thing you want to do is shock a patient who has a pulse. So just keep an eye, come back to this in your book. It's another good crosswalk, and I'll try to get it onto the Dropbox as well. Begin chest compressions and attach the AED as soon as available when you have a witnessed cardiac arrest. So if the patient dropped and they went into cardiac arrest, it was witnessed, and somebody can start CPR, then that is our goal. Immediately starting CPR, and then as soon as you can get the AED in, getting that attached. Of course, we're probably not going to be right there when a patient goes into cardiac arrest. So, if it looks like they've been doing quality CPR, then I can go ahead and attach the AED. Once I've walked through the AED protocol, whether it's shocking or not, I need to consider the fact that my patient will either A, get a pulse, B, no pulse but no shock advised, or C, no pulse but shock advised. I might debate whether I'm waiting for ALS and continuing shocks and CPR on scene, or if ALS is going to take too long to respond, am I putting them on a backboard and beginning the transport? If my patient at any point regains a pulse, it's time to transport. Don't sit around. This is not somebody who's going to sign a patient refusal or should be allowed, because we've got to figure out what caused the cardiac arrest. When my patient when the AED gives me 3 no shocks with CPR in between each, 2 minutes, then I'm going to transport my patient as well. If my patient goes into cardiac arrest in the vehicle, in the ambulance, or stays in cardiac arrest while I'm transporting, I need to consider the fact that every bump on the road is going to impact analyzing the rhythm with the AED. So if I'm analyzing my patient to be considered for a shock, I need to stop the ambulance, or at least slow it down. I'm gonna, if I've got an AED, I'm not waiting for ALS. And even if I don't, I can do CPR and good bagging, moving the oxygen around, moving air in and out. I should not delay defibrillation if I have my AED just to get an ALS provider. Guys, the AED is a BLS skill. The AED is a BLS skill. And hopefully, if you've been successful, you'll have a patient who gets what we call ROSC, Return of Spontaneous Circulation, ROSC. If you've done a good job, if they're a savable patient, if their heart rhythm responded appropriately to the shocks, then they will get their circulation back on their own. When this happens, we've got to maintain the airway. So they may get their heart rate back, but still be breathing not enough to support life. If they're still good doing that, then we're going to place them on a non-rebreather. We're trying to keep high oxygen saturation. We're going to get a set of vitals now that they have a heart rate, and we're going to transport. I think the big thing to remember, though, is that just because they've come out of cardiac arrest does not mean they won't go back into it. So a patient who gets return of spontaneous circulation can just as easily go back into cardiac arrest. So don't remove the AED pads, don't sit them up and think, oh, no big deal. Be prepared and monitor them. This is an unstable, high priority patient still. Follow all of that and make smart choices in how you treat your patient and what you do, and get them to the hospital providing appropriate update. If they do get their heart rate back and they do change their consciousness level, also don't forget to call the hospital and just say, hey, they're no longer in cardiac arrest, or hey, they are in cardiac arrest. The last thing you want to do is have the hospital prepare for one type of patient and then suddenly be faced with the other.